This is the fifth in the cardiovascular system, talking about blood pressure and pulses. The specific topics, blood pressure, going to talk about systole, diastole, and some things you may not know about systole and diastole, using some case scenarios in there. And then with pulses, do you know where to check for a pulse if you're come across a person that you worry about? And the best places to check, and then what the pulse will tell you, what tachycardia and bradycardia will tell you, tachy being fast and brady being slow. And then I have a list of lab structures that are going to be converted to a PDF, and you'll be able to have access to those with a link on the YouTube posting. So blood pressure is a measurement of systole and diastole. Systole is that first part of when the heart is squeezing. So the systole is measuring the pressure that the heart generates within those arteries that leave the heart. So notice that there's the left side of the heart, the right side of the heart. What you're measuring with the blood pressure is the left side of the heart. Okay, so quick question again. Which ventricle generates the systolic blood pressure that's being registered by the external blood pressure machines, or with a cuff and a stethoscope? So the right ventricle or the left ventricle? The answer is the left ventricle. The left ventricle is generating the greatest pressure, and this is what the pressure waveform looks like, with the left ventricular systole being generated the highest, and then when it comes down during that relaxation is the diastolic phase, and that's when blood is filling up the left ventricle. So during diastole, the left ventricle is relaxing. The coronary arteries are getting filled along with the ventricles. And notice how that pressure drops off as it goes to the arteries, the capillaries, and the venules. And the veins, notice the veins still have up to 20 millimeters of pressure in them. Okay, so the right ventricle is generating pressure as well, even though it's not being measured with the blood pressure cuff. It can be measured, and this is with a catheter. It's called a Swan-Ganz catheter. It can be placed into the right internal jugular vein, goes into the right atrium, goes through the tricuspid valve, and then you can be floated into the pulmonary artery. And when the balloon is inflated, it will occlude the pulmonary artery, and you'll be able to get a pressure reading of what type of pressure the right ventricle is generating. So this is when these are the different waveforms for the catheter. As you're putting it through, the right atrium has this lower pressure, and then into the right ventricle generates these 30/6 or so, and then it goes into the pulmonary artery, and when this is occluded at the tip is the pulmonary artery wedge pressure. This is not routinely done. There are certainly complications associated with a pulmonary artery pressure, including rupture, and that is not a totally uncommon occurrence. And when that does rupture, usually death ensues. Usually patients bleed to death, unless you're in the operating room and can quickly repair it. So going back to hypertension, remember hypertension kind of is a cyclical nature, because the high high flow of blood, the turbulent flow of blood creates plaque. And then this plaque develops, and then prehypertension starts and hypertension follows. And then these arteries become like pipes. So they're poorly distensible. They don't have that spring back. And ultimately, what happens is the heart has to work so much harder to generate pressure into these pipes that are non-distensible. So this hypertension is really tough on the heart, can cause left ventricular hypertrophy and outflow tract obstruction and heart failure. So hypertrophy is when this muscle gets bigger and bigger, as you can see on this bottom picture. The left ventricular wall gets bigger and bigger. And it causes outflow tract obstruction because as this hypertrophies, notice how it can actually occlude this outlet going through the aortic valve. And this is called subaortic stenosis. And on EKG, you'll see these waveforms much bigger, the QRS much bigger, because the electricity is having to go through all this muscle. And eventually what happens is this, the left ventricular, the chamber isn't big enough anymore, and it doesn't fill a lot of blood with a lot of blood. So it becomes actually a smaller chamber at that point as it gets bigger, as the walls get bigger and bigger. All right, so where can a blood pressure be taken? Can it be taken upper arms, wrists, ankles, all of the above? And the answer is all of the above. So really anywhere you can place the bladder of the blood pressure cuff over the artery so that you can occlude the artery and hear the sounds, or the machine can pick up the changes in flow. And for patients that have extremity problems, like patients in the vascular lab, they may only have a leg as an extremity that you can use. One arm's being used for shunt placement, like they're having dialysis placement, and the other arm still have a shunt that's working, and you can't use it. Or patients can have breast cancer and have radical mastectomies, and you're not wanting to use a blood pressure cuff on their arms. Blood pressure is generated with taking this cuff and actually occluding the artery itself. So it needs to go up higher than what you think the patient's blood pressure is, like 20 or 40 millimeters higher. So if a person's blood pressure is 120 over 80, usually you'll want the blood pressure cuff to go over that number, well over that number. So as you're slowly reducing the pressure of the cuff on the artery, you start hearing these sounds, and the sounds are called Karot cough. And the sound is the turbulent flow of blood coming through the artery. And when that relaxes, when that turbulent flow relaxes enough, when you hear those sounds go away, that is designated as the diastolic pressure. So you inflate to occlude the artery, you slowly deflate until you hear the first sounds, and you stay going slowly so you don't miss when the loss of sound. And that's the diastolic pressure. So here's a case scenario. You've got a patient, they have a very slow heart rate. Maybe it's an athlete. And you're deflating the cuff very quickly. How would the cuff pressure reading be affected? Would the blood pressure reading be artificially high, or would you get an artificially low reading? The answer is you're going to get an artificially low reading because you're going to miss when that sound would have occurred. This is the problem with automatic blood pressure cuffs because they have a standard setting of how fast the blood pressure is dropping. So in a person with a very slow pulse rate and you're getting a low blood pressure, take a handcuff and use a this kind of a cuff with a stethoscope to get an accurate reading of what the blood pressure truly is. So the best places to find a pulse on an adult, the carotids is good. It's very accessible. The only problem is if you're pressing on someone's neck that has plaque, there's a potential of you're knocking off a piece of plaque or a piece of blood clot that is formed on the plaque. So you kind of got to be careful when you're pressing on people's carotids, older people. The brachial pulse is nice. It's non-obtrusive, not offensive. Same with the radial. When you're in the emergency room and a patient's on the table and they're being treated for instance, an auto accident, people are going to be working on the extremities, trying to find IVs, and the anesthesiologist may be trying to intubate. So another great place to find a pulse that's big is going to be the femorals. And of course, the popliteal, dorsalis pedis. Dorsalis pedis is a great place to check for peripheral circulation. If they've got a fairly good dorsalis pedis, it means you're getting a pretty good generated blood pressure throughout the rest of the systemic circulation. Okay, so what about newborns, infants? So you're helping out an emergency C-section. Upon delivery, the baby is not breathing, and the pediatrician is using both hands to bag and mask the infant. As a matter of fact, this is a picture of me doing a newborn resuscitation. This is in a low resource setting. So both my hands are being used, and I'm asking my assistant to please check the pulse to check how well the baby's doing. So question, where are you going to check? You've checked the femoral carotid, you can't find any pulse. Where is another easy place to check? Would you go for the foot, the wrist, or the umbilical cord? The answer is the umbilical cord. It stays pulsating for up to 30 minutes after delivery. Some of them can be closing down as short as 5 minutes, but some can be pulsatile for up to 30 minutes. Remember that the umbilical cord has 2 umbilical arteries coming from the baby's heart and 1 umbilical vein that was coming from the placenta. So the vein at this point is going to be collapsed, but they've still got these arteries. And after delivery, these umbilical arteries should be oxygenated if the baby's breathing. So this is the upper image is what it looks like in utero before delivery. Okay, next case scenario. You've come across a car accident and you find a man laying next to the car. His pulse is very fast, and the medical term for that is tachycardia. Blood is covering his shirt. Okay, so you've got tachycardia, there's evidence of injury. What could be happening? What scenario is going through your head? Blood loss, The other medical term for that is hemorrhage, anxiety, fear, or both. Answer is both. All right, next case scenario, car crash. A woman sitting next to the car. She has no apparent injuries. Her heart rate is very slow. What could be happening with her? Internal injuries? Is she having a sympathetic response or a parasympathetic response? The correct answer, this is going back to neuro anatomy. She might be having a parasympathetic response. And just a refresher on these pathways, the cranial nerve 10, the vagus nerve, can be stimulated with a very upsetting event. Fear, something just upsets you terribly. You can get this visceral response that activates the parasympathetic nervous system. And the cranial nerve 10, part of the parasympathetics, affects the SA node and the heart rate slows. So bradycardia, possible causes for bradycardia could be a vasovagal response from cranial nerve 10. Medications, beta blockers can slow the heart rate if someone is getting an overdose of their propranolol. They can have sixth sinus syndrome, like an injury to the sinus node, for instance, cardiac surgery, or as we saw in the previous presentation, patients can develop a non-functioning sinus node as they get older, called sixth sinus syndrome. And causes of tachycardia can include fear, pain. So pain and fear can actually cause tachycardia or bradycardia. They can actually stimulate the vagus nerve, or they can cause sympathetic stimulation. Hypovolemia, so the heart rate is trying to compensate for the low blood volume. Medications can cause tachycardia. One common drug is cocaine. Diseases, infections, sepsis will cause a tachycardia, and a cardiac arrhythmia like ventricular tachycardia, atrial flutter, AFib. All of those things can cause a cardiac arrhythmia that causes a rapid heart rate. All right, did someone say cocaine? Cocaine causes euphoria, tachycardia, and because of the tachycardia, you can have a potential for having a heart attack. So what class of drug is cocaine? Is it an amphetamine like speed? Is it a narcotic like heroin? Hallucinogen like LSD? Local anesthetic like lidocaine? Amnestic like Valium? Or a dissociative drug like ketamine? The answer is it's a local anesthetic. That's what class of drug it is. It falls into that class. Any medication that has the last letters cane are local anesthetics. That's the class of drugs. So Novocaine, Marcaine, you can guess what kind of medication it is by the end of the name. The pharmacology of cocaine is that it releases massive dopamine, and dopamine is one of those great feel-good hormones. So besides euphoria, its other effects or side effects are potent vasoconstrictor. So it raises the blood pressure really high. It constricts down all the small vessels. And so it can cause vasoconstriction of the coronary arteries, and patients can have, or people can have a heart attack, even though they're younger. You can still get a heart attack if you take too much cocaine. It actually, I remember cocaine being used in the operating room. And it's because it's a great local anesthetic. For surgery on the nose, it will cause temporary vasoconstriction. It'll stop a nosebleed very quickly. And it's great for pain control because it's a local anesthetic. The side effects, though, if it's used extensively, is you can shut down those tiny vessels in the nose so much over a long period of use, you can completely lose your nasal septum. And of course, as we talked about, arrhythmias, heart attacks, hypertension. So with sustained hypertension, let's go back to that. Blood flow is only going through the heart muscle, feeding the heart muscle during diastole. So if you increase the heart rate, you shorten the diastolic filling time. So blood is not getting to the myocardium. But this is just a depiction of what happens during diastole and systole. So look at systole is when it's being squeezed down. It shuts down the coronary blood flow. Not only are coronaries not being filled, but the delivery to the myocardium is reduced. And this is a good point with labor contractions. When women are in labor, if they have a sustained uterine contraction, the placenta gets shut down and the placenta is not getting any blood flow either. So the baby, during those sustained contractions, you'll see the fetal heart rate drop. Now the next few slides I'll go through very quickly because these will be in a PDF if you want to print it out or study them for the structures. I took the images from visible body and then labeled them with these numbers to go through the different views and the different structures. And notice when the heart is lying in the chest, it's the right ventricle that is exposed, that's just beneath the sternum. So if you get stabbed in the chest, most likely that stab is going to hit the right ventricle. These structures, venous structures, superior vena cava, inferior vena cava, aorta is arching out behind the pulmonary artery, which is here. So this is the back side of the heart. So you're looking at the patient's face. The patient is facing away from you. And what you're seeing is the left atrium. The left atrium is receiving oxygenated blood from the lungs. So those vessels, 6, labeled with number 6, they're pulmonary veins. They contain oxygenated blood coming from the lungs. And this upper one is the pulmonary artery. And notice how it's bluish, so that is deoxygenated blood that's on its way to the lungs. If you remember this structure, coronary sinus. And the coronary sinus is dumping deoxygenated blood from the heart myocardium, and it's dumping it into the right atrium. So the conduction system, SA node, the AV node is up in here where the confluence of the chambers. This is your backup system. If you develop sick sinus syndrome, you've got this AV or atrioventricular node as your backup. Going to the bundle of His, bundle branches, and then of course the Purkinje's. This is the anterior view of the heart. This is the pulmonary circulation. The right ventricle going to the pulmonary artery and then splitting. And posterior view, blood coming from the lungs oxygenated, landing into the left atrium. So in summary, the blood pressure went through the systolic, diastolic, went through the pulses, some of the great ways to check. Now, in a situation where, you don't know the person, and, maybe they're laying down, but they're awake, you can gently come up and touch their hand and unobtrusively take someone's pulse and check it without being offensive. So radial pulse is probably my preference if someone is awake. And we talked about the heart anatomy and the heart physiology. And what is oxygenated and deoxygenated blood and the blood flow patterns. So a very simple depiction of deoxygenated blood going to the right side of the heart, deoxygenated blood going down the pulmonary artery to the lungs, coming back as pulmonary veins back to the heart, and then the oxygenated blood going to the body and, of course, to the coronary arteries. So the right side of the heart is a low pressure system. The pulmonary artery generates a bit more pressure, maybe 20 systolic, going to the lungs for oxygenation. And this is a simplistic, but it's picture, but usually, the images you'll see are going to be the superior vena cava, inferior vena cava. So two veins are entering the heart. The pulmonary artery is going from the right ventricle to the lungs. Pulmonary veins are going back to the heart, and the aorta is coming from the heart. So this is the oxygenated side, the red side, and the deoxygenated side. So remember, with pulmonary circulation, red does not always mean artery. It means oxygenation. Okay, so remember coronary arteries at the top. This is looking down of the aorta at the top, looking at the cusp, the three cusps of the aorta, and filling blood in the coronary ostium. Remember, a rapid heart rate decreases that diastolic filling time. It also decreases the amount of oxygen flow through the heart muscle. And anybody with coronary disease is at much greater chance for having a heart attack if their heart rate goes up. And that's why you'll see patients that have a heart attack. The first thing medication they'll do is put them on like a beta blocker, which slows the heart rate down. And these are the events, and I'll let you go through this in the PDF. Notice that the aortic and pulmonic valves are open when the mitral and tricuspid valves are closed. Any questions, please leave comments and subscribe. Thank you.